Hello friends, I am Aditya Lakshman Dange and today is our topic non-steroidal anti-inflammatory drugs. Let us start with the topic. So, these are the subtopics of today's lecture that are preferential COX-2 inhibitors, second, selective COX-2 inhibitors, third, para-amino phenol derivatives, fourth, topical NSAIDs, then choice of the non-steroidal anti-inflammatory drugs, and then analgesic combination. So let us start with the lecture. So these are the preferential COX-2 inhibitors. Before starting that, what are the COX-2 inhibitors? We will see. Production of prostaglandin. In the production of prostaglandin, we know prostaglandins are formed from phospholipids. Phospholipids are converted into arachidonic acid and then with the cyclooxygenase they are converted into prostaglandins. Beside the prostaglandin synthesis inhibitor, some are the other mechanisms by which the nimesulide will act. These are the reduced superoxide generation by neutrophils, inhibition of PAF and tumor necrotic factor alpha release, and free radical scavenging. Nimesulide is completely absorbed and 99% is plasma protein bound. Half-life of this drug is 4 to 5 hours and excreted in the urine. Normally nimesulide are used in the short-term pain relief like sports injuries, sinusitis, dental surgeries, renal colic, arthritis, post-operative inflammatory condition, fever, low back pain, ENT disorder. The most important is no cross-reaction of aspirin and other NSAIDs related to bronchospasm. This is a specific usefulness of the nimesulide. And the ADRs are epigastric pain, nausea, loose motion, heartburn, rash, pruritus, somnolence, and dizziness. GIT tolerant but ulceration, fumitant hepatic failure. It is the main ADR related to COX-2 inhibitor nimesulide. Before starting with the main topic, we will discuss what is difference between COX-1 and COX-2. The COX-1 is a constituent enzyme of our body which has the normal which will act in normal conditions also, but COX-2 is an inducible enzyme. The main meaning of that is the COX-1 is a little inflammation effect and COX-2 is the main cause of inflammation. Means COX-1 has a simple body functions also and present normally at the all places of the body, but the COX-2 are mainly present at the sites like kidney, endothelium and CNS. So next one is the preferential COX-2 inhibitors, that is diclofenac. Diclofenac has an analgesic, antipyretic and the anti-inflammatory effect on our body. The efficacy is similar to that of naproxen. It inhibits the prostaglandin synthesis and somewhat it is a COX-2 selective. Why we are mentioning that it is a COX-2 selective somewhat? Because COX-2, we see earlier, the COX-2 has a main effect on the inflammation and COX-1 maybe have the normal function in our body. Then, the reduced neutrophil chemotaxis and reduced superoxide generation by which the diclofenac is acting. No antiplatelet reaction. Then 99% 99% of the drug is absorbed by the plasma protein brown, and the half-life is about to 2 hours. Its tissue penetrability and synovial fluid penetration is good, so it will store in the joints and relieve the joint pain for the longer duration. The uses of diclofenac are rheumatoid arthritis, osteoarthritis, bursitis, ankylosing spondylitis, bursitis, toothache, dysmenorrhea, renal colic, post-trauma, and post-inflammatory condition. The adverse drug reaction of diclofenac are mild epigastric pain, nausea, headache, dizziness, and rashes. The less gastric ulceration and bleeding, but the risk of heart attack and stroke is more. The next topic is a selective COX-2 inhibitors, that is celecoxib, etoricoxib, and parecoxib. These drugs inhibit the COX-2 without inhibits COX-1 benefits. The less peptic ulcer occurrence and less ulcer bleeds. It do not depress TXA2 production, that is COX-1 of platelets. These do not inhibit the platelet aggregation and do not prolong bleeding time, but reduce prostaglandin I2 production. So what are the disadvantages of this drug? This reduces the prostaglandin 2 production by vascular endothelium, leading to increased prothrombotic effect and enhanced cardiovascular risk. Its uses are normally in patient with a high risk of peptic ulcer and perforation at the lowest dose and the shortest period. Contraindications are the patient with the history of IHD, hypertension, CHF, that is chronic heart failure, and CVA. Let's move on to next topic. COXIB contraindications. Other concern of the selective COX-2 inhibitors, that is efficacy. COX-1 generated prostaglandins may play a role in the inflammation. Broad range of action. Gastroprotectivity disturbed. Injury and the H. pylori induced COX-2 gastroprotective PG synthesis locally delay in the ulcer healing. Concern over COX-2 physiological role. Constitutes in the JG renal cells, sodium and the water retention, edema, precipitation of CHF and rise in the BP. So move on the next slide. Para-amino phenol derivatives, that is paracetamol. आपल्या सगळ्यांच्या सर्वात जास्त यूजमधली गोळी म्हणजे डोकं दुखतंय क्रोसिन घेऊन टाक, अंग दुखतंय डोलो घेऊन टाक. या सर्व ड्रग्सचं मेन कंटेंट म्हणजे पॅरासिटामॉल. So paracetamol is first introduced in 1887 as a phenacetin, which is banned now because of nephropathies. It is detylated active metabolite of phenacetin, and it is analgesic like aspirin, antipyretic, and raise pain threshold, but no prostaglandin inhibition except COX inhibition in brain. Here notice that no peripheral anti-inflammatory action, but it has a COX inhibition in brain. Now some important points about paracetamol, that is it is good promptly acting antibiotic, additive analgesic action with aspirin, means central plus peripheral, negligible anti-inflammatory action, poor inhibition of the prostaglandin in peripheral tissue, but high in CNS. Explanation: why the poor inhibition of prostaglandin in peripheral tissue but high in CNS? The inflammatory area peroxide generation is happen, so it cannot inhibit the COX in the presence of peroxide in the periphery, but centrally it is lacking, so it has the COX inhibition in brain, and it is also known as COX-3. No stimulation of the respiration or effect on acid-base balance unlike aspirin, and no increase in the cellular metabolism. No gastric erosion or platelet function alteration. Next slide. Paracetamol contraindications. First, the kinetics. The paracetamol is an orally absorbed drug, and 1/4 is plasma protein bound, that is 25% is plasma protein bound. The T-half of this drug is 3 to 5 hours, and metabolism is by conjugation with glucuronic acid and sulfate. The ADR is not so much. It is safe and well tolerated drug, and but it shows analgesic nephropathy after few years. Now, the acute paracetamol poisoning. Commonly, it occurs in the children with low hepatic glucuronidation and conjugation capacity, and also in the adult with the large dose, that is more than 150 mg per kg or greater than 10 gram in adult. So what are the manifestations? Nausea, vomiting, abdominal pain, and liver tenderness. After 12 to 18 hours, centrilobular hepatic necrosis and renal tubular necrosis and hypoglycemia and coma. Jaundice after 2 days. High dose poisoning cause fulminant hepatic failure and death. So, next slide. Paracetamol toxicity. Why the paracetamol toxicities happen? We normally use paracetamol in our daily life. Whenever the pain is happen, we use paracetamol. But why paracetamol toxicity is happening? The N-acetyl parabenzoquinonimine, highly reactive arylating minor metabolite of the paracetamol, normally detoxified by the conjugation with glutathione. But when we consume the large dose of paracetamol, glucuronidation capacity gets saturated and more NAQBI form. The hepatic glutathione depleted. Metabolites bind with covalently to protein in the liver and renal tubule cells that will cause the necrosis of these cells. The 5 to 6 gram in alcoholics. It is very dangerous. Treatment. In early cases, induction of vomiting is by activated charcoal and other supportive measures. The N-acetylcysteine 150 mg per kg IV for 15 minutes followed by same dose for 20 hours. It replenishes the glutathione store and prevents the further binding with the cellular content. The next topic is the paracetamol uses. Most commonly used over the counter drug. Headache, mild migraine, musculoskeletal pain, dysmenorrhea, etc. The first choice in the osteoarthritis. Not effective in rheumatoid arthritis. It is the safest antipyretic in the children's. No Reyes syndrome. Advantages are: first, the lesser gastric irritation, ulceration, and the bleeding can be given in the ulceration also. Second, does not prolong bleeding time. Third, hypersensitivity rarely. Fourth, no metabolic disturbance. Fifth, can be given in all age group, pregnancy, lactation also. Sixth, no significant drug interaction. So move on the next topic, that is topical NSAIDs. We all use topical NSAIDs in our daily life. That is Volini, Moo, Nice Gel, our Jandu Balm. NSAIDs are also effective topically as a gel, spray, etc. What are the advantages of the topical NSAIDs? Attain the higher concentration locally in muscles and joints, and low blood levels. GI and the other systemic ADRs are minimized, and first pass metabolism is avoided. And the common sense is that when we apply topically on the site of injury, it will direct effect on the pain and relieves the pain in a short duration. So kinetics, it is slow absorption, that is 10 times longer to attain the peak plasma concentration to oral dosing. High blood level, 15% of the same oral dose. Local concentration up to 4 to 6 mm high and 25 mm in muscles. Overall efficacy depends on site. The uses are in osteoarthritis, sprain, sports injuries, spondylitis, and, and soft tissue, rheumatism, etc. Safety is no issue, but efficacy, local application, massaging, counter irritant, methanol, and methyl salicylate. More efficacious in short-lasting musculoskeletal pain. So next topic is how to choose the NSAIDs. Firstly, if the history of asthma, then use selective COX-2 inhibitors. If patient is with hypertension or risk of heart attack, so COX-2 inhibitors. Pediatrics, paracetamol, elderly, low dose of NSAIDs. In pregnancy, paracetamol. So choice of NSAIDs. These are some important points, that mild to moderate pain, we will use paracetamol or the low dose ibuprofen. Second, post-operative acute short-lasting pain, that is ketorolac, propionic acid derivatives, diclofenac or nimesulide. Acute musculoskeletal osteoarthritic or injury pain, we will use paracetamol, propionic acid. Next, exacerbation of rheumatoid arthritis, acute gout, ankylosing spondylosis, we will use naproxen, piroxicam, idomethane, methacin. Next, gastric intolerance to NSAIDs, we will use selective COX-2 inhibitors. If history of asthma, nimesulide or selective COX-2 inhibitors. In hypertension, or risk of heart attack, COX-2 inhibitors, and PA derivatives. Pediatrics, paracetamol, and elderly low dose of NSAIDs. Pregnancy, we will use paracetamol. Fast-acting ones, fever, headache, and other short-lasting pain, SR preparation for chronic long-lasting pain, and IHD, hypertension, diabetes mellitus, consider the drug interaction. Combination, aspirin plus paracetamol is a superadditive. Also, paracetamol and ibuprofen and diclofenac and paracetamol. So, let's move on to MCQs. Question number 1. Which of the following is a common preferential COX-2 inhibitor used to relieve the pain and inflammation? So, on option A, aspirin, option B, ibuprofen, option C, celecoxib, or option D, paracetamol. Answer is C, celecoxib. Next one. Question number 2. Which functional group is present in para-amino derivatives? Para-amino phenol derivatives. Option A, amines, option B, alcohol, option C, ketone, or option D, carboxylic acid. So, option A, that is amines. The next question. What are the primary purpose of topical NSAIDs? Option A, pain relief, option B, lowering blood pressure, option C, treating bacterial infection, or option D, boosting the immune system. Yes, option A, pain relief. Next question. Which of the following is a common condition that topical NSAIDs are used to treat? A, high cholesterol, option B, allergies, option C, osteoarthritis, or option D, migraines. C, osteoarthritis. Next question. How do topical NSAIDs differ from oral NSAIDs? So, option A, topical NSAIDs are taken by mouth, while oral NSAIDs are application to the skin. No, it's wrong. B, topical NSAIDs are applied to skin, while oral NSAIDs are taken by mouth. Yes, this is true. Option B. These are the answers of the MCQ.